Welcome back, students. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, so in our last session, part 83, we laid the groundwork with the medical side of major diagnostic category 04. Today, we're diving straight into the really complex world of thoracic surgery, interventional pulmonology, and critical tracheostomy overrides. Let's get right into this masterclass.
Let's take a quick look at today's syllabus. We're going to cover MDC-04 architecture, respiratory procedure drivers, root operation precision, audit defense, and finally wrap it up with a summary. Think of this as your roadmap for mastering these surgical hierarchies.
All right, jumping right into Section 1, MDC-04 architecture, specifically the medical versus surgical partition. We really need to understand how the grouper fundamentally works here.
So, what exactly triggers a surgical partition? Well, a case gets assigned to a surgical DRG simply because it includes a procedure that meets the CMS definition of a major operating room procedure. This is a huge deal. It shifts cases into high-impact categories like the major chest procedures found in MS-DRGs 163 through 165. The golden rule here? A significant OR procedure will actually override the medical principal diagnosis to completely drive that surgical DRG assignment.
You can really see the sharp contrast when we put these pathways side by side. On the medical side, if there's no significant OR procedure, things just process normally. But the second a major OR procedure happens, boom, it overrides the medical principal diagnosis entirely. The whole reimbursement and grouping pathway pivots to a surgical DRG. It's a massive, massive shift in how the case is weighted and ultimately paid.
Moving right along to Section 2, respiratory procedure drivers. Let's see how this actually plays out in the real world.
We absolutely have to follow the principal procedure rule. This rule dictates that therapeutic procedures, think major open thoracotomies, airway stenting, or endobronchial valve placements, always override diagnostic procedures or ancillary tests like a basic chest X-ray. Interventional pulmonology acts as a major bridge here. You've got to sequence that principal therapeutic procedure first to accurately trigger the surgical DRG.
Let's walk through a super common scenario to see this coupling logic in action. Step 1, a patient comes in admitted for pneumonia. Step 2, unfortunately, they develop acute respiratory failure. Step 3, they end up needing mechanical ventilation for more than 96 hours. This specific combo, acute respiratory failure coupled with prolonged mechanical vent time, frequently triggers a major complication or comorbidity, an MCC, which, as you know, significantly bumps up that DRG weight.
And that brings us to a massively critical CDI distinction. The difference in codes here is literally just based on time. If ventilation is under 96 hours, it's coded as 5A1945Z. But the second it crosses that 96-hour mark, it becomes an entirely different code, 5A1935Z. You have to track those ventilation hours precisely in the discharge summary or RT notes. Why? Because if you pair that prolonged ventilation with a tracheostomy, it can trigger a massive pre-MDC global overarch.
All right, let's dive into Section 3, root operation precision. This is where we get into the nitty-gritty, extreme refinement phase of ICD-10 PCS.
When you're looking at the ICD-10 PCS body system structure, the first character is your section, and the second is your body system. For thoracic surgery and pulmonology, your absolute foundation is character B, the respiratory system. Every single respiratory intervention you code is going to map right back to this specific character.
Now, let's talk about two root operations that are notorious for tripping coders up during audits: resection versus excision. Resection means cutting out without replacement all of a body part. Excision, on the flip side, means just cutting out a portion of a body part. The trick here is remembering that in ICD-10 PCS, a body part isn't always a whole organ. It could be a specific anatomical subdivision that has its very own distinct value in the manual.
Think of it kind of like a puzzle. Take a percutaneous liver biopsy as a visual metaphor here. If we apply that exact same logic to the lungs during, say, an endobronchial ultrasound, the needle is just grabbing a tiny sample of tissue for diagnostics. It's removing a piece without replacing it. Since it's only a portion, that's an excision, and we use the qualifier diagnostic to flag excisions that are biopsies, just like this one.
So, applying this directly to thoracic surgery, a total lobectomy of the lung, that's a resection. Why? Because an entire lobe, which is its own specific anatomical subdivision, is completely removed.
But a segmental lung biopsy, that's an excision, because you're only cutting out a portion of that lung tissue. The rule of thumb? Always code to the most specific anatomical subdivision possible.
Here's another one auditors absolutely love to scrutinize: drainage versus extirpation. Drainage is all about helping gases or fluids escape, like using a chest tube to remove excess air or fluid from the pleural cavity. Extirpation, though, means taking or cutting out solid matter. Think pulling out a pulmonary thrombus or a foreign body. You've really got to nail this difference to make sure you're selecting the right character for fluid versus solid matter.
Next up, the approach character, which drastically changes your final code and DRG. An open approach is exactly what it sounds like, a traditional incision through body layers, like a full open thoracotomy. Percutaneous means entry by puncture or a minor incision. And then, percutaneous endoscopic adds visualization to the mix, like with video-assisted thoracoscopic surgery or VATS. Properly identifying this from the operative report, totally non-negotiable for getting into those DRG families 166 through 168.
Okay, moving into Section 4, Audit Defense and CC/MCC Capture. This is where we defend our clinical validity and make sure we're capturing the true severity of illness.
You really have to adhere to the crucial sequencing rules here. Complications of care, like a post-op persistent air leak, a bronchopleural fistula, or post-op respiratory failure, they absolutely must be coded as secondary diagnoses to capture true CC or MCC status. Plus, auditors are always watching how you distinguish between expected post-op atelectasis and true pneumonia, so getting these secondary conditions locked down is fundamental.
And you know, documentation is quite literally everything. Look at the poor documentation side here. The discharge summary just says chest pain. That vague language leads straight to incorrect DRG assignment, major revenue loss, and huge compliance risks. But look at the good documentation side. Acute anterior wall MI, linked to a specific procedure, with secondary diagnoses listed perfectly. That level of clarity is exactly what drives accurate, defensible reimbursement. So what do you do when the documentation looks like that poor example? You send a CDI query. Here's a great real-world example. Doctor, please clarify if the documented respiratory failure is acute, chronic, or both. This specific phrasing locks down the exact severity of the post-operative complication without leading the physician. It is an incredibly vital tool in your audit defense toolkit.
All right, Section 5, Summary and Teaser. We've covered a ton of ground today, so let's consolidate this into a few actionable takeaways. Here are your main takeaways. Remember, major OR procedures drive surgical DRGs, overriding medical principal diagnosis completely. Sequence those therapeutic procedures first. You need to flawlessly distinguish between root operations like resection versus excision, and please meticulously verify mechanical ventilation duration, especially to catch if it crosses that 96-hour threshold and triggers a pre-MDC tracheostomy override. Coming up in our next lesson in this masterclass series, we'll be shifting gears to Part 85. We're going to do an advanced medical DRG deep dive into major diagnostic category 01, the nervous system. You definitely won't want to miss the complex coding rules for cerebrovascular events and nervous system disorders. I'm going to leave you with this one provocative question. Are your clinical documentation queries precise enough to defend your surgical DRG assignments against payer denials? Really think about that as you review your charts this week. If you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. See you in the next explainer.